Mitral valve repair has been regarded as the optimal treatment for all mitral valve dysfunctions and is actually the most commonly performed surgical procedure in North America for mitral regurgitation. The aim of this talk is to comment and summarize the available data on mitral valve repair versus replacement in their areas of degenerative, rheumatic, endocarditic, and functional mitral valve regurgitation. Degenerative mitral valve disease is actually 60 to 70% of all surgical mitral regurgitation, and it's a spectrum that ranges from a single prolapsing valve to diffuse myxomatous degeneration with bileaflet prolapse and annular dilatation. This is the most repairable form of surgical mitral valve disease and is overwhelmingly recommended as far as surgical approach. The well-accepted advantages of mitral valve repair consist of lower operative mortality, improved preservation of left ventricular function, and greater freedoms from prosthetic valve-related complications such as thromboembolism, anticoagulant-related hemorrhage, and endocarditis. There is also abundant retrospective data supporting the durability of valve repair as equal to or even superior to mitral valve replacement, even in cases of complex valvular pathology. With regard to the durability of repairs, it is important to note that the proper standard for durability comparisons is with mechanical mitral valve replacement. Biological prostheses are known to be associated with limited durability in the mitral position, and reoperation rates markedly increase at the 10-year mark postoperatively. There are no randomized trials comparing the outcomes after mitral valve repair and replacement in degenerative disease, and when considering the strength of the available retrospective studies with respect to long-term survival, it is important to remember that patients undergoing the two procedures commonly exhibit very different characteristics pertinent to long-term survival at baseline. For instance, the most potent predictor of long-term survival following mitral valve operation is preoperative left ventricular ejection fraction. The strongest studies considering the survival advantages of repairs are those that include risk-adjusted comparisons of outcomes. The balance of risk-adjusted survival data show improved mid- and long-term survival for mitral valve repair compared with replacement, even in the elderly. Of particular interest is the work of Danishmand and colleagues, who considered 989 patients undergoing isolated valve procedures for degenerative disease. Compared to the 284 patients having replacement, the 705 patients undergoing repair were younger and less likely to undergo coronary artery bypass grafting, but also had lower preoperative ejection fractions, higher rates of heart failure, and preoperative arrhythmia. With repair and propensity analysis, you did see important survival differences, and they increased over time, at up to 21% better survival at the 10 to 15-year mark. And in this study, patient age did not diminish the benefit of repair. Here are the survival curves from that study, and data like this supports an aggressive policy of repair for repairable degenerative mitral valve disease in the vast majority of patients with such mitral regurgitation. It is, though, useful to consider the extreme end of degenerative mitral valve disease. We have demonstrated that in a certain select group of patients, repair is not associated with a survival benefit. These are patients who have extremely complex degenerative disease, a group of patients that are typically older, very symptomatic, and with more comorbidities. In our institution, this represented 7% of all mitral valve regurgitation patients. And in this group, long-term survival was not governed by whether repair or replacement was undertaken, much more likely governed by the patient's comorbidities. These are the survival curves from that propensity-matched study. And in this very selected group, after propensity matching, you can see that survival was similar regardless of repair or replacement. So in degenerative disease, basically all but the most complex, most comorbid patients show a survival benefit according to the data that's available. Rheumatic mitral disease is a lot less common in North America and European countries. This is a complex sort of mitral valve pathology. It can involve every component of the mitral valve, and the data here overall suggests survival benefits for repair, along with greater freedom from thromboembolic complications. That is at the expense of durability in the available data. A representative series of this population come from Yao and his colleagues, considering 573 patients between 1978 and 1995. In this series, 25% of the valves were repaired, 28 were replaced with biologic valve, 47 replaced with a mechanical valve, and even after risk adjustment in this series, operative mortality was better with repair, as well as long-term survival. In considering this and other similar studies, we, along with the current guidelines, recommend consideration of repair in rheumatic disease only if a durable and successful repair is likely, or when there's a question about the advisability of long-term anticoagulation. In the case of endocarditis, the indications for surgical intervention include congestive heart failure, intracardiac extension of the infection, such as an abscess, sepsis unresponsive to antibiotics, systemic embolisms, and in some cases, the presence of large vegetations. The main goals of the surgical treatment of mitral valve endocarditis is the eradication of all infection and obviously patient survival. Systematic reviews have found that mitral valve repair is possible in endocarditis approximately 39% of the time. Similar to the degenerative MR experience, valve repair was associated in a recent review with lower hospital mortality and reduced long-term mortality. This was confirmed by meta-regression analysis in the review that we've cited here. Of course, this is all subject to bias in that patients with fewer comorbidities and less aggressive infections may be the ones more likely selected to be repaired. Additional advantages of repair over replacement in this series included decreased risk of stroke, recurrent endocarditis, and reoperation. As implied before, not all patients with endocarditis are candidates for repair due to a variable extent of tissue destruction. In the service of the first aim of surgical treatment, which was, as you recall, eradication of infection, the goals are to remove all grossly infected tissue, and this should be done without concern for the possibility of repair. In fact, resection should err on over-excision of leaflet tissue to ensure the eradication of the infectious process. Only after everything is resected can the possibility of reconstruction be assessed. Repair can be approached with the full armamentarium of mitral valve repair techniques, including patching of perforations, vegetectomy, resection of the involved leaflet, leaflet patching with either autologous or bovine pericardium, etc. Monofilament suture should be considered over braided suture to prevent bacterial sequestration. And in the event that replacement is the only option due to the advanced state of infection or perhaps delayed presentation, mechanical valve replacement is most suitable for younger patients with native valve endocarditis due to its durability. Tissue valves we would consider acceptable for patients greater than 60 years old with either native or prosthetic valve endocarditis, and only for selected younger patients with prosthetic endocarditis. Ischemic mitral disease is regurgitation that's a consequence of coronary disease. It can be short-lived and associated with an acute infarction or ischemia, but by and large it's caused by completed infarctions in the circumflex or right coronary distributions. Those infarctions result in changes in the geometry and function of the left ventricle and the annulus and lead systolic leaflet restriction and annular dilatation. The choices for the surgical treatment of IMR include either revascularization alone or revascularization in concert with mitral valve repair or replacement. Currently, there is general agreement that revascularization alone is not an acceptable surgical strategy in the case of severe regurgitation, although in the area of mild to moderate MR, that question has remained open and has been extensively debated. Until recently, this was debated with retrospective data, but recently there has been reported a CTSNet trial that has been reported comparing the effectiveness of mitral valve repair procedure in combination with coronary artery bypass grafting versus CABG alone in patients with moderate ischemic mitral regurgitation. The CTSNet trial considered 301 patients and randomly assigned these patients with moderate ischemic mitral regurgitation to either CABG alone or CABG plus mitral valve repair as a combined procedure. The primary endpoint of this trial was left ventricular end systolic volume index, which is a measure of left ventricular remodeling at 1 year. This trial did not show a higher degree of reverse remodeling with repair versus CABG alone, and there were no significant between-group differences in major adverse cardiac or cerebrovascular events, deaths, readmissions, functional status, or quality of life at 1 year. The addition of mitral valve repair was associated with a significantly longer bypass time, longer hospital stay after surgery, and more neurologic events, although moderate or severe regurgitation was less common in the repair group at 1 year. The clinical significance of this, though, is yet to be determined, and longer-term follow-up is needed. Based on these results, the authors concluded that the routine addition of mitral valve repair to CABG in this moderate ischemic regurgitation group may not be warranted. Our policy, as we await the results of additional prospective data, is to favor a strategy of mitral annuloplasty in addition to revascularization in this population only in those patients whose symptoms are dominated by heart failure. And now, in patients with severe regurgitation, current guidelines do support mitral valve surgery, either repair or replacement, in those patients undergoing CABG. No actual recommendation is made as to repair or replacement, and this has been quite the subject of controversy. Recently, the first results of the first prospective randomized trial considering the relative merits of repair versus replacement in the setting of severe mitral regurgitation were released. This was a trial of 251 patients with severe ischemic mitral regurgitation, and these patients were randomly assigned to undergo repair or chordal-sparing replacement at the time of surgery. 74% of repairs and 75% of replacements also underwent concomitant CABG. Primary endpoint of this trial was left ventricular and systolic volume. The investigators found no difference in this measure or in 30-day mortality or survival at 12 months between patients who underwent repair versus replacement. The rate of moderate or severe MR at 12 months after surgery was 32.6% in the repair group, and this is to be compared with 2.3% in the replacement group. But there were no differences in the rate of a composite of major adverse cardiac or cerebrovascular events, functional status, or quality of life at 12 months. This finding is similar to what had been shown in previous retrospective data prior to this trial, and a lot of the difficulty in the ischemic mitral regurgitation population is quite heterogeneous. For instance, we have shown that a mitral annular diameter of 3.7 centimeters or more, as well as a tenting area of greater than 1.6 centimeters squared, is associated with a higher degree of annuloplasty failure. And one of the limitations of this work is that presence or absence of these sorts of risk factors were not captured in the patients that were studied. We have also separated out this heterogeneous population and shown that depending on your risk status, a patient may or may not derive a survival benefit from repair. We considered 397 patients undergoing repair for mitral regurgitation and 85 undergoing replacement. In our series, 95% of the patients had concomitant CABG. We used propensity matching to create 5 groups over a spectrum of risk in this heterogeneous population, having either replacement or repair. So the highest risk patients in group 1 showed the worst survival, and that did not differ according to repair or replacement. But as the lower risk patients in quintiles 3 to 5 were observed, we did find a survival benefit from repair. So putting all of this together, we recommend revascularization and repair in patients of lower risk and without the echo finding features that I mentioned earlier that are associated in our experience with repair failure, those being a diameter of 3.7 centimeters of the annulus or greater, along with a tenting area of greater than 1.6 square centimeters, as well as those having a complex jet or lateral wall motion abnormalities. However, in those high-risk patients, those with more severe heart failure, emergency cases, and those with high-risk features on echo, we do join with the findings of Acker and colleagues in recommending a chordal sparing bioprosthetic replacement at the time of CABG.